Black and indigenous Americans are more likely to die from cancer than any other racial groups in the country, even though they don't get cancer as much. That's according to the American Association for Cancer Research, which is just out with its yearly report on disparities in cancer research and treatment and what the field can do to close those gaps. I'm joined now by Dr. Colin Weekes from the Mass General Cancer Center. He is on the steering committee for this report. Dr. Weekes, thanks for being here.
Thanks for having me.
What surprised you most in this year's report?
I mean, I think the big surprise, and not necessarily this is a surprise per se, but it's that overall things are improving, right? It's just really that the gap is sort of maintained. So the gap in outcomes are maintained, but if you look at sort of in general patients with cancer, the outcomes are improving for all patients, although the differential magnitude of benefit is different.
So am I right that the outcomes are improving for all patients and some of the disparities are also being reduced, correct?
That is correct.
I think we have a graphic actually from the report that points that up. It highlights the narrowing of the gap between the overall cancer rate between the white and black populations. It was 33% in 1990. It's down to 11.3% in 2020.
Yeah.
Still substantial, not as big.
Yeah.
Why does that gap exist?
You know, it has to do with resources, right? At the end of the day, the resources that we have in life put us at different risks for things like stress, obesity, other factors that result in patients developing cancer. And then the other component is that the resources also impact our capacity to access care and access the sort of most avant-garde care for our giving cancers. And then it also impacts our capacity to screen patients, right? So even if we do screening and we detect that a person has a risk for cancer, how do we get them to the next stage where they actually get that risk assessed? And so it's a multifactorial approach, but I think the bottom line in society is that patients who have less resources, whether they happen to be black or other indigenous populations, really it's the resources that they have available to them that put them in these risk factors. Or,
tell me if I've got this right, there's also the question of socioeconomic class, right? Which obviously is linked to demographics, but I think we've got another graphic that I'd like to pull up. You were talking about screening. There's a huge gap when it comes to people who have a good chunk of money, who are living at 400% over the federal poverty level, and people who are living near it and might qualify for Medicaid. 81% of people who are 400% over the federal poverty level get screened for breast cancer. Presumably women getting screened for breast cancer, 65% of lower income people, 83% for cervical cancer versus 67%. So same story.
Yeah, so I mean, socioeconomics is resources said in a different way. It's still the same problem, right? Is having access to these opportunities for screening, but also having the time, right? If you're working hard and your job doesn't allow you to take the time to go get screened, that's also an important part of this conversation.
Yeah, I had a doctor's appointment in the middle of the day today, and I was able to go to it because here they're very accommodating when it comes to that sort of thing. But if you're working a shift at a fast food restaurant, you might not be able to do that.
Absolutely.
Okay, given that socioeconomic gaps are huge and very entrenched and intractable, are there things that the medical profession could be doing as those gaps continue to exist to continue narrowing the disparities that we're talking about here?
So I think a big thing that medical centers can do, and I think right now in Boston in particular, there's sort of a reorganization of cancer care in the city and in the state of Massachusetts, right? And so as that occurs, the more that people of disparate backgrounds sort of express their desire to get appropriate care, right, that's going to be important. So what I think that the institutions can do, such as MGH, can really begin to do a better job of engaging the communities in which they serve and really listening to those communities. An example of something of those natures, we are going to be doing something called the Cancer Equity Colloquium. It's a 2-day symposium on cancer equity in June. And the goal of that is to bring patients or the general community next to in a room with people like me, the business sector, so that we can all talk and realize that actually, number one, we're all humans, not that different, right? But as we engage each other, we realize that there might be unique opportunities for collaboration and develop unique opportunities to sort of address cancer equity.
Where are you going to be doing that 2-day event?
Right, so this will be on June 14th and 15th at the MGB headquarters in Somerville. It'll be a 2-day event. It's a Friday and a Saturday, and it's going to have a real sort of diverse plethora of speakers addressing cancer equity in different ways.
It sounds like a first-time thing, right? You haven't done this.
This is actually the third time we're doing it.
Oh, my bad.
Yeah.
No.
But it's the third time we're doing it, but it's growing each year.
Why are more young people developing cancer?
I think it has to do with our environment that we live in. There's more toxins that we're sort of associated with. It also probably has to do to some degree our diet and what we're sort of consuming. And then maybe there's some degree of genetic drift that's occurring. But once again, I think it's a multifactorial problem that we don't really have a great answer or a hold on, but it is something that we're seeing.
You started off with good news, which went against my tendency to emphasize the negative, and bad news, which I think is shared by a lot of us in the media. Yeah. Are there any other pieces of good news in the report that are worth highlighting?
You know, I think there's something that's sort of ongoing, which is this concept of ancestral oncology, and sort of understanding how ancestry impacts cancer disease as well as cancer care. And what that has to do with is there may be unique opportunities for sort of drug development that can lead to unique opportunities for better outcomes. So one thing about cancer in general, in the last decade in particular, there's been tremendous impact and outcomes for patients in general. What has not happened, though, is we've not had diverse populations participate in those clinical trials. Mm-hmm. And then, so as a result, there are some people who are being left behind, i.e. this gap that we're talking about. And so one of the really important things going forward is, and this is what institutions are focusing on, is diversification of clinical trial participants, mm-hmm. As that may also increase different genetic subtypes that may respond to therapies. But we also know that patients who participate in clinical trials, just simply participate in clinical trials, they have a better outcome than other cancer patients.
Oh, I didn't know that.
Yeah.
I never heard
and it has to do with the fact that they're just monitored so closely, so things get addressed very quickly, and as a result, patients ultimately do better.
And again, I think I heard you say in the middle of that sentence that you just spoke that there are disparities when it comes to who participates in clinical trials.
Absolutely. And that's one of the things I think that MGH is focusing on. I think that will be a thing that a lot of cancer centers going forward is going to focus on as well. And that's in part the FDA has also made this an important component of the regulatory process as well. So there's lots of movements in different ways to try to address this issue of cancer equity. But it's going to take some time, and it's going to take some real hard conversations.
How long do you think it will take before the medical profession can get to where it needs to be, to where people are sufficiently engaged? And this is front of mind, not just in some communities, but in all communities.
So I think that's a loaded question.
It wasn't supposed to be.
But let me explain why. So if the NCI was developed 50 years ago, mm-hmm. and so over the course of these past 50 years, this gap still exists, right? Now, I think what's happening is that there's increased focus on this gap now because of, I think, leadership changes and sort of, and as a result, I think we are moving forward. It has been shown that if you take patients who have similar backgrounds to their doctors, there's mm-hmm. a benefit associated with that, right? So as a community focus on the next generation of physicians and healthcare providers, it's also going to be important that we look to increase the diversification of those individuals as well.
I'm really glad you mentioned that. I had meant to bring that topic up, and I was going to boff it and not do it. So thank you for catching it. Yeah. Dr. Colin Weekes, thank you. Really a pleasure talking with you.
Thank you.